Well, good evening. Welcome to the EDS Awareness Educational Series webinar. My name is John Furman. Before we introduce our speaker, we'd like to give an overview of our free programs for those attending for the first time. So we'll discuss who we are, what are our programs, our newest programs that we just introduced. We'll then introduce our speaker and do a brief Q&A. So again, my name is John Furman. I manage the National EDS Awareness and Chronic Pain Partners nonprofit organization based in Cincinnati, Ohio. My daughter, Deanna, was diagnosed with hypermobile EDS in 2008, the same year my wife, Carol, passed away with breast cancer. I was a caregiver for my wife who struggled with undiagnosed EDS for over 30 years. We introduced our program at the 2012 EDNF conference to help EDSers form independent local support groups and spread EDS awareness in their communities. We have been a sponsor for these conferences for the last 7 years. We've helped to support and start over 120 support groups to date. Each group is given their own free website with a link from the directory map. We receive feedback that conferences provide valuable information and social opportunities that many cannot afford physically or financially to attend in person. So we decided to bring the speakers to you through the free EDS Awareness Educational Series. We have over 85 webinars covering more than 50 topics posted on our webinar page at edsawareness.com. We typically meet monthly at 7:30 Eastern Daylight Time. All the programs are free. The meeting announcements and whenever possible, the webinar recordings will be posted on our website at edsawareness.com for later replay. You can receive email announcements for future sessions by requesting the free guide on our site. Tonight's presentation is sponsored by Body Support Store, where you'll find over 250 products selected by EDSers for EDSers. Proceeds from the store and donations to our nonprofit organization help fund our programs. Please visit our store and check out the helpful products that we offer. We're very excited about a program that we're presenting in May in Mason, Ohio, which is north of Cincinnati. So this will be for the May EDS Awareness Month. More information is available at the leadeds.com site. We have a special entertainer who will be there with us, Mandy Harvey. If you've ever watched America's Got Talent, she was the fourth runner-up last year in the judging. She got on her stage in her stocking feet and sang beautifully, and she is deaf. She's going to tell her story and also entertain us at this program. This program is a collaboration of a number of groups: EDS Wellness, Kindred Nielsen Miles. We also have participants from Dysautonomia Support Network and the Mast Cell Disease Support Group. So it is participants from the Dayton, Ohio, and Cincinnati, Ohio support groups are helping as well. We announced last year our new EDS Physician CME educational program. This is a free program. We have 6 programs on the site. We just added Dr. Afrin, mast cell activation syndrome, and that is getting a lot of support. So please recommend to your doctors the Ehlers-Danlos-CME.org site. You can also print a brochure from that site. Just a general disclaimer, this presentation contains general information about EDS. Members of the EDS community voluntarily participate in this program. The information is not advice. If you are having medical problems now, please call 911 or the emergency services in your location. Always consult your doctor before making any changes to your treatment. So we're very excited to have Dr. Alan Pocinki back for the third webinar that he's presenting for us. The topic of this webinar is sleep disorders in EDS. Dr. Pocinki is a general internist in a private practice in Rockville, Maryland. He has been interested in joint hypermobility syndromes and related autonomic and sleep disorders since the late 1990s and speaks regularly on these subjects at local and national organizations. His publications include two authoring in 2017 articles, which we have posted on our site. He's received a variety of awards and recognition for service to his profession, as well as the quality of his practice. He received his medical degree at Cornell University Medical College. Dr. Pocinki has incorporated into his presentation results of our How Does EDS Affect Sleep survey that we've had on our EDS awareness site for a few years, and we've had over 5,000 respondents. This is his third webinar that he's presented to our membership. Note, he is not taking new patients nor responding to emails. So now's your chance to ask those important questions. So thank you for joining us, Dr. Pocinki.
Thank you, John, and thank you for all the good work that you and the folks at EDS Awareness do. And thank you to all joining us this evening. So the problem of this talk on sleep disorders in Ehlers-Danlos and related syndromes, I've subtitled a panoply of paradoxes, or a collection of paradoxes, because a lot of the things here are counterintuitive or the opposite of what you might expect. I will be discussing off-label uses of a number of medications, and I have no financial conflicts of interest to disclose. As John mentioned, the EDS awareness folks did a survey, and I will be incorporating some of the results of that survey to sort of illustrate and back up some of the points I'm making and support some of the things that are consistent with observations I've made over the years. So an overview of what we're going to talk about tonight. Basically, it's important to understand that the autonomic nervous system is the part of the nervous system that regulates all involuntary body processes, heart rate, blood pressure, breathing, digestion, things like that. I happen to think that the autonomic nervous system is important for regulating sleep as well, though that is not a universally accepted belief. Autonomic dysfunction is very common in Ehlers-Danlos and other hypermobility-related syndromes, and by that I would include things like fibromyalgia and chronic fatigue syndrome. And autonomic dysfunction underlies many of the symptoms of Ehlers-Danlos and these other related conditions. And what I'm going to try to show to you tonight, or help to convince you, is that the most common type of sleep disorder seen in the hypermobility syndromes appears to have an autonomic basis. So we need to understand that. We need to talk a little bit about the basics of the autonomic nervous system. It's a pretty simple system. Basically, there's an accelerator and a brake. The sympathetic nervous system is your body's fight or flight stress response, and it's helpful to think of that as the accelerator. Generally speeds things up. The parasympathetic nervous system is the brake, slows things down, and in contrast to fight or flight. We refer to the parasympathetic nervous system as the rest and digest part of the autonomic nervous system. So the basic feature of autonomic dysfunction in Ehlers-Danlos and many similar syndromes is that the job of the autonomic nervous system is basically to keep things stable. It works very hard to maintain your body temperature, to maintain your heart rate, to maintain your blood pressure, to speed things up when they need to be sped up, to slow things down when they should be slowed down. When it doesn't work properly, there's a failure to modulate the stress response. The body will either not slow things down or speed things up when it should, or speed things up too much or slow things down too much inappropriately. So one of the important constructs or concepts that I think makes this concept of autonomic dysfunction a little easier to understand. To realize this is a construct and not a there's no true physiology to this, but I find it helpful to talk about an adrenaline reserve, the idea of having your own gas tank. And basically, sleep is your body's major chance to put gas in the tank, and then all kinds of other daily activities and stresses tend to drain the tank. The central paradox of autonomic dysfunction is that the more depleted this tank gets, whereas you might think that the lower the reserves, the less gas in the tank, the slower everything will go. In fact, it's just the opposite. The more depleted, the more run down, the lower your reserves get, the more exaggerated your stress response is. The more your body overreacts to minor stresses. So while you're trying to conserve energy, your body is wasting it overreacting to things. And unfortunately, that overresponse to stress often then triggers an overcorrection, which then may trigger another overresponse in what I call the autonomic roller coaster. And that's easy to see here. I'll spare you the technical details, but basically this is an in-office system where we can measure sympathetic and parasympathetic activity independently. So in healthy people at rest, there's very little, the autonomic nervous system isn't doing very much. Then we have them do slow, deep breathing. And if you've ever seen somebody who's very upset and told them, slow down, take a couple deep breaths, that's why that works. Stimulating the parasympathetic nervous system deep breathing tends to stimulate the parasympathetic nervous system. Then we have people rest for a minute. Then we have them clench and strain as if you were severely constipated and straining, or as if you were trying to blow up a balloon or something. And that stimulates a sympathetic response. Then we have people rest. And then this is one of the more helpful things. Normally when you stand, and lightheadedness on standing is one of the common autonomic symptoms that Ehlers-Danlos patients have. Normally when you stand, as you stand, your blood pressure drops a little bit. Your body has sensors in your neck to detect that, and it increases, it bumps up your sympathetic activity a little bit, raises your heart rate and raises your blood pressure just for very, very short period of time. And then your body does other things like constrict blood vessels and move some blood in from other parts where it's not being used to maintain blood flow to your brain while you're standing up without having to use excess adrenaline or excess sympathetic activity. So in somebody who's got autonomic dysfunction, in this case, somebody with lightheadedness on standing, you can see what happens is this patient, I'm trying to get to this part of the slide, but you can see here that this patient on standing, their blood pressure drops, and they have this exaggerated, they make way more adrenaline than they need, but then almost instantaneously, their body hits the brake even harder. And then again, there's an up and down that happens. Over here, this person is sitting quietly doing nothing, and their body's decided something's a little too slow, better hit the gas. That little bit of gas triggers this exaggerated braking. Then it's like, whoa, that's too much brake, we better hit the gas again. Well, that's too much gas, we better hit the brake again. So this up and down is going on constantly, and also look and see how much energy this person is wasting on this crazy roller coaster compared to the little bit of energy this person has expended. Okay. So I include this slide just to make the point that this roller coaster reflects an imbalance rather than a permanent condition. So this is somebody who, as you can see, her autonomic nervous system was just all over the place. And she was severely disabled, barely able to get out of bed, barely able to stand. And it took, in this case, 1.5 years of treating her pain and her sleep problems and all the other problems she was having. But after 1.5 years, her autonomic nervous system, as you can see here in the second slide, was nearly normal. So, sorry. So this is really the crux of the talk. This is one of the two major, most important pieces of this talk, and that is to look at, this is what we call a hypnogram. These are the sleep stages or your sleep architecture. And normally you start out in shallow sleep, and then you get a big chunk of deep sleep, shallow sleep, REM, shallow sleep. Usually there's a little more deep sleep here, then shallow REM, the rest of the night. So you can see there's a fairly regular cycle with most of the deep sleep early in the night. So this is a very typical sleep pattern we see in a patient with Ehlers-Danlos syndrome who says, gee, you know, I'm not having any trouble breathing, I'm not thrashing, I'm not moving around, I'm not, you know, having wild nightmares all night. I fall asleep, I sleep through the night, and I wake up feeling like I haven't slept. So you can see right away, this person has no deep sleep at all, essentially no REM. There's nothing that looks like a cycle here at all. This person is just stuck in shallow sleep the whole night. What you can't see here is that in the sleep lab, we define an awakening as a disruption to the continuity of your sleep that lasts more than 30 seconds. It turns out that most people have to be awake for at least 2 minutes to remember having been awake. So this person remembered having been awake twice. She thought she'd woken up twice, and in fact, she woke up 23 times. But in addition to those 23 awakenings, if the continuity of your sleep is disrupted for less than 30 seconds, we call that an arousal. So in addition to her 23 awakenings, she had 125 arousals. So in fact, her sleep was disrupted 150 times, and she had only had a recollection of 2 of them. So this is why sleep misperception is another paradox. Because you're asleep, you're really not aware of what's going on. And in fact, a surprising number of Ehlers-Danlos patients over the years have told me that they sleep fine. Some even say, you know, I'm a great sleeper. I can sleep anytime, anywhere. But when I say, gee, I think that means you're not a good sleeper, that kind of puzzles them. So then I ask them, well, do you feel rested when you get up? And they often respond, no, I never feel rested. I wake up feeling like I haven't slept, and I don't think I know what feeling rested would feel like. This is not just a problem in Ehlers-Danlos. A lot of people with sleep apnea don't realize they're having trouble breathing all night because they're asleep. And even some people with what we call periodic limb movements of sleep who are moving around a lot at night aren't aware of that because they're asleep. So fortunately, this is a place where the data from EDS awareness survey supports my own experience. And if you just look at the very first line here, the first bar at the top, you'll see that a full 75% of over 5,000 people who responded to the survey said they wake up feeling unrefreshed. So no matter what your medical problems are, if you can't get a restful night's sleep, it's going to be hard to feel better. Another illustration of this problem of what I call sleep misperception is if you ask people how long it takes them to fall asleep, about 1/3 of them will say, well, it takes an hour or more. And another 1/3, wisely, say that they have no idea how long it takes them to fall asleep. And in fact, that's the right answer. Because unless you're looking at the clock constantly, which you shouldn't be doing if you're trying to fall asleep, then you really don't know how long it took for you to fall asleep, unless you have a Fitbit or an Apple Watch or something else that tells you when you fell asleep. So what's the story with all these disruptions? Why did this person have 150 disruptions to the continuity of her sleep? So here's a very simple graph showing heart rate along with these sleep stages. So here you see pretty clearly that every time this person woke up, here, 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 every time she woke up during the course of the night lines up perfectly with a spike in her heart rate, as if she's making little surges of adrenaline constantly through the night. This person at least is not stuck in shallow sleep all night. She's at least trying to cycle through deep sleep, REM, deep sleep, shallow sleep, REM, little shallow sleep, deep sleep, but superimposed on this almost normal looking cycle are all these vertical lines, all these disruptions. Here she's actually asleep, awake, asleep, awake, asleep, awake, multiple times in just a short period of time. And even though she's trying to get into deep sleep, each time she gets into deep sleep, she just wakes right out of it. So this can occasionally be a problem with sleep lab software, or any sleep software will tend to add up all these little bits of deep sleep, and they might come up with something like, gee, this person had 30 minutes of deep sleep, which is low, but not but still an overestimate of what they really got, because really if you get 30 minutes, 3, 4, 5 minutes at a time, that's really not restful at all. So another paradox, and this gets a little technical, is just like as I said, the more depleted, the less energy you have in your system, the more your body overreacts to stress. Is something we call heart rate variability, and that's the way scientists measure autonomic function, in particular sympathetic activity. And again, this may seem paradoxical, that less sympathetic activity, in a sense, the less energy, less adrenaline you have in your system, the more your heart rate is going to fluctuate and bounce around. So again, this idea that the more run down, the more tired you get, the more depleted your energy reserves get, the more exaggerated your heart rate fluctuations will be. And as you've just seen, the more your heart rate fluctuates, the more disrupted your sleep is, and that just makes your fatigue worse. So this is a nasty, vicious cycle that's very hard to break. This slide I included just to show that this person, for whatever reason, had her autonomic nervous system was quiet, her heart rate was calm and steady as it should be while you're asleep, and so she got a nice, almost interrupted big chunk of deep sleep here. The rest of the night, again, if you had a ruler, you'd see that every one of these awakenings here, I think she had about 25 of them, lines up with a spike in her heart rate. So, question that comes up often, and a very good one, is how do we know that these sleep disruptions and these heart rate spikes aren't just from pain? And the answer is we don't. And in fact, in some patients, pain medication at bedtime will substantially improve the quality of their sleep, will reduce their awakenings, and help them feel better. Unfortunately, people misperceive pain too, often think they're in less pain than they really are. Or think, gee, why should I take pain medication at bedtime? I'm going to be asleep. And in other people, as I'll show you, adrenaline blocking medications to suppress the adrenaline underlying these heart rate spikes will reduce awakenings and improve sleep. But if it's pain that's triggering the adrenaline surges that's disrupting sleep, then of course the optimal treatment is to treat the pain and not just to block the adrenaline. So, and consistent with that, here's some data from the survey again, showing that about 2/3 to 3/4 of people said that, excuse me, said that it's hard for them to get comfortable, they have to move around, and pain clearly interferes with their sleep. So now that you understand this, and you recognize what's abnormal about this second sleep graph on this page, I included this a second time to make the point that this second study was read as normal by a board-certified sleep doctor. Excuse me. So this is a cartoon to sort of drive home that point. In this case, it's the physician saying to the patient who's just had an MRI that the MRI reveals that your head is riddled with conventional wisdom, when in fact what most of you have had to deal with, I would guess, is physicians whose heads are riddled with conventional wisdom. So one explanation for why would a board-certified sleep doctor describe that as a normal sleep study when clearly the person had no deep sleep and all these disruptions, awakenings, and arousals? Why would that be considered a normal sleep study? Well, there's a phenomenon in the sleep community called the first night effect. It's well known that people often don't sleep well on their first night in a sleep lab, or in general, their first night in any new place. You don't sleep soundly, your body's not comfortable, you're a little nervous. What if something happens? What if, something I'm not used to? I better be just sleeping a little more shallowly. And in fact, for years, I've called this a on alert phenomenon. In some sleep literature, it's referred to as the night watch phenomenon. And you can see how this might be a protective mechanism to be hyper vigilant for threats in a new environment. Certainly, if you think in an evolutionary perspective, if you're able to hear that wild animal sneaking up on you and be ready for that, that would confer a survival advantage for you. So interestingly, study done a few years ago found that found a physiologic explanation for the first night effect. What they found was that in fact, one part of the brain, or one hemisphere, one half of the brain, is actually sleeping normally and fairly deeply, while the other half of the brain remains in a more alert, shallower state of sleep. So, and this paper was entitled Night Watch in One Brain Hemisphere, associated with the first night effect in humans. And so, as I said, they found a difference in sleep depth between the two hemispheres of the brain, and they concluded that first night effect is a manifestation of one hemisphere being more vigilant than the others as a night watch to monitor unfamiliar surroundings during sleep. But additionally, they found that the bigger the difference between the side of the brain that was sleeping soundly and the side that wasn't, in other words, the more alert the side with reduced sleep depth was, the longer it took the person to fall asleep. And this, I think, is analogous to people who have trouble falling asleep because they feel like their brain is still awake, that they're having racing thoughts, or just they're tired, they're asleep, but part of their brain is still awake and won't shut down. Also, the more alert side not only was more sensitive to deviant stimuli, to unexpected lights or sounds or something going on, but that part of the brain there was an enhanced evoked brain response, meaning there was actually an exaggerated response and a faster response. The other half that was sleeping soundly might have responded, but not nearly as vigorously or as quickly. So this study was done in healthy people, and what they found was that on subsequent nights in the sleep lab, they did not see this difference between the two hemispheres of the brain. Unfortunately, in Ehlers-Danlos and related conditions, it seems as if every night is the first night. So more data from our survey here. I want to point out at the top of this list, the idea, almost 3/4 of people, over 5,000 people responding, said they wake up several times during most nights. So if you think about the person who remembered waking up twice, who actually woke up 23 times and had another 125 sleep disruptions, if almost 75% of people are aware of waking up several times, most of those people are probably waking up, way more than that and having a lot more sleep disruptions than they're aware of. And again, in terms of this night watch idea and being more sensitive to external stimuli, you'll see that almost half of people said They've always been light sleepers, that noises easily disturb their sleep. And again, very appropriately for the study about half the brain being asleep and half being awake, almost half of the people in the survey said, even when I'm asleep, I feel like I'm half awake. And here it is just graphically. Again, I think this is even more striking here. Almost 3/4 of people say they wake up several times. And again, we can pretty safely conclude that they're really waking up a lot more than that. So, and then as for the question about how do we know that these disruptions aren't just pain related, and I said we don't. Well, in fact, we see that, and I showed these data again, that 2/3 to 3/4 of people do have pain. But I also wanted to point out in this same set of figures, if we look for any evidence of autonomic dysfunction affecting sleep, well, here we are with this idea of it's hard to turn off my thoughts. So that's this idea of hyper arousal, of just too much adrenaline, being too alert, being too awake. The room has to be dark because people tend to overreact to little bits of light. The room has to be quiet because you're overly sensitive to small noises. And the room has to be just the right temperature because the autonomic nervous system doesn't do a good job of regulating body temperature or adjusting to changes in outside temperature. So, so whatever you can do to make the room quiet, dark, and a comfortable temperature will help minimize autonomic reactivity during the night. And again, just the pictorial version of those same numbers. So this is kind of a catch-22 slide that people aren't happy with because it seems circular. To improve sleep, you need to improve your autonomic function, and to improve autonomic function, you need to improve sleep. So that may sound like it's kind of impossible to do, but fortunately, what's also true is that if you can improve sleep, your autonomic function will improve. And if you can improve your autonomic function, your sleep will improve. So this is more doable than it sounds. So I can show you this slide again of the person whose autonomic nervous system was totally out of control, but after a fairly extensive course of treatment was almost normal. So how did she get from the slide on the left to being back to almost normal? Well, basically this person was totally exhausted. You recall my fuel tank analogy, and the goal of treatment was to replenish her reserves. So how do we fix the sleep? Well, we have to address underlying causes of autonomic dysfunction. And the major ones are pain. So we already talked about pain itself disrupting sleep, but pain is also a major energy drain day and night. So it's kind of a double whammy. It aggravates sleep and it aggravates autonomic dysfunction almost independently. Fatigue, again, seems paradoxical, but fatigue itself tends to aggravate autonomic dysfunction in as much as people are tempted, or in many cases forced, to push through fatigue. So if you're exhausted and you have to do something anyway, then in essence, you're drawing down your reserves. You're dipping into that tank that you're trying to replenish, and you're further depleting it just to try and get through your day. Additionally, any degree of dehydration will aggravate autonomic dysfunction, because if you're dehydrated, your body's first response is to kick in a little extra adrenaline to compensate for that. Low blood sugar needs to be avoided. If you're somebody whose blood sugar fluctuates a lot, hypoglycemia is a major life or death stress that your body will respond to with a sympathetic autonomic surge. And then, of course, emotional, cognitive stresses, family stresses, all kinds of everyday stresses are also very draining and aggravate autonomic dysfunction. And this whole concept, this whole approach to treatment is well summarized in this little cartoon, which, of course, oversimplifies things a little bit, but helps people understand sort of the big picture of how do I get better. The energy pool is empty, or at least pretty low. How do I replenish it? Well, I need to get a more restful night's sleep, because that's my major chance to put gas back into the tank. And then many things that happen during the course of the day. Again, pain is a big energy drain. Pushing through fatigue makes things worse. Dehydration, cognitive effort draws from that same energy pool as physical activity does. Emotional stresses, anything family, all kinds of stuff. So you can see there's all kinds of things sucking up energy, taking gas out of the tank, and sleep is really your big chance. So that's why I said earlier, if you can't get a decent night's sleep, it's gonna be hard to get better. So again, how do we do this? How do we refill the pool? How do we get back to what I call autonomic balance, get off the roller coaster? Well, you need better sleep. Typically that means longer sleep, but especially better quality sleep. Pain control is really critical. As I said, people often tend to underestimate their pain, or with all the publicity about the opioid problem, people are reluctant to take pain medication when they often need to. Be careful not to push through fatigue. Take breaks when you can. If you have to do something, and then rest before you try to accomplish another task. Adequate salt and fluid is very important. I'll just throw in my own observations on that, are that the vast majority of people that I see who have problems with lightheadedness and are told to eat plenty of salt and drink plenty of water are getting too much water and not enough salt. Generally, water should be, you're better off drinking electrolytes and not drinking plain water. Plain water can actually aggravate your salt fluid balance. And then I mentioned earlier, trying to avoid blood sugar fluctuations if you're somebody for whom that's a problem. And to the extent that you can, minimize other stresses. And that may mean something as simple as, not watching the news on TV, or having somebody else drive you somewhere if traffic where you live is as bad as traffic is here in the Washington area. So here's another person. This is one of the original home sleep monitors we had probably more than 10 years ago. This is somebody's sleep in the sleep lab. And you can see that early in the night, he had a small chunk of deep sleep. The rest of the night, just shallow awake, shallow awake, asleep. And his home sleep monitor looked like this, where orange is awake. And you can see that he not only had a bunch of short awakenings, which he wouldn't have remembered, but he had a number of longer awakenings, and that he had very little deep sleep. The other thing that's interesting about this particular study is you can see that each time he tried to get into REM, he'd wake up. REM, wake up. And this is a pattern we see in people who have vivid dreams and nightmares. So they get into REM, they start to dream, the adrenaline kicks in, and they wake up. But this is what his sleep looked like after about 7 or 8 months, I think. And hopefully now you'll recognize that this is about as close to normal as a sleep study you could want. He's got a little shallow sleep right away, gets a nice big chunk of deep sleep, shallow REM, shallow, another chunk of deep sleep, shallow REM, almost no interruptions. So this is your goal. This is what you'd like your sleep eventually to look like. So how do we improve the quality of your sleep? Well, first, don't overlook the obvious. Good sleep hygiene means, don't spend your day in bed watching TV, reading, doing other things. Try to use your bed primarily for sleeping so that your body will associate being in bed with sleeping. A comfortable mattress is important. Over the years, it's really surprised me how many people, when I ask them about their mattress, will very reluctantly admit that they're sleeping on a 15 or 20 or even 25-year-old mattress. Different people like different kinds of mattresses, but probably a 15 or 20-year-old mattress is not going to be comfortable. We talked about the importance of both dark and quiet, because the autonomic nervous system will be overly sensitive to little bits of light or little bits of noise. And then sleep apnea is more common in hypermobile people, and that's something that needs to be looked for, but should be treated only if it's significant. So this is a little cartoon where the doctor says, well, you've been counting sheep and no rest even after counting the whole flock. You should be tested for sheep apnea. So sleep apnea is something, again, that's That's surprisingly common, and I've been surprised over the years sending people for sleep studies who I was looking to see how much deep sleep and how much shallow sleep and how many disruptions they had, and lo and behold, they had significant sleep apnea. On the other hand, this is a patient, and I'll spare you the details, except to make a couple of points here. One is that this is what we call a hypnogram, and this one piece of paper here shows the sleep stages: shallow sleep, deep sleep, the top line being awake, heart rate, different types of apnea, central apnea, obstructive apnea, respiratory arousals, body position, movement, all on one piece of paper, so that you can see what is associated with what. And when you see here is the most striking thing on this page is this young woman's heart rate. And she told me that as soon as she gets into bed, her heart starts racing. And sure enough, she's right. And she goes in the sleep lab, and she was awake most of the night. She finally fell asleep in the middle of the night, slept for about an hour and a half. But when she did fall asleep, she got immediately into deep sleep, had a nice long chunk of uninterrupted deep sleep. And look at how calm and quiet her heart rate was while she was sleeping. And then heart starts going bananas again. She's awake. But unfortunately, you'll also see a couple of apneas here, a couple of apneas here, one or two here, a couple of hypopneas, which are shallow breathing, but really nothing of any significance. And yet the board certified sleep doctor who read this woman's sleep study told her she needed to come back to be fitted with a CPAP mask and be treated for sleep apnea. So before we get to medication, and we've gone over the basics of dark, quiet, comfortable mattress. Beyond that, there are non-pharmacologic things you can do to improve the quality of your sleep. If you have apnea, then treating it is important. Things like guided imagery, deep breathing, sequential relaxation are ways to get your body to calm down if you're in this hyper-aroused, overly alert state. Some people find that instead of quiet, they'll sleep better with some background noise. White noise is generally sort of a static sound. And if you ever listen to a white noise machine, it's this funny sort of very dim, crackly static. What's called pink noise is more like the hum of a background fan. And that's something that lots of people say they have to sleep with a fan. And I think most people should know that alcohol is not good for your sleep, so should be avoided. So getting to medication, hopefully you have the idea from these various sleep studies and the responses to the surveys about how important pain is in disrupting sleep, and how big a factor autonomic dysfunction is in disturbing sleep, that most of the time medication of some kind is going to be needed to improve the quality of sleep. Typically, multiple medications with complementary effects are going to be needed, including a medication for pain, something else perhaps to reduce arousal, something perhaps to increase deep sleep. Finding the right combination can be frustrating. It's often trial and error. Different people do better with different medications. The newest generation of home sleep monitors can be helpful, because if you make some changes either to your lifestyle or to your medication, you might not notice right away the next morning, wow, I slept so much better last night. But if your sleep monitor shows that you only woke up 5 times instead of 15, then you know that whatever you've done is beneficial, and that over time you'll begin to feel better as you have more restful sleep. So what surprised me about these data from the survey, and I showed you this before, but in this case, I wanted to point out this one orange line in the middle here. Only 30% of people said they took any kind of prescription medication to help improve their sleep. This despite the fact that 3/4 of them said pain disrupted their sleep. And what we talked about, autonomic dysfunction and the different types of medications that might improve that. So getting into medications, I'm not going to go through all the details of every different medication and all the wrinkles and the fine points of choosing different things. but we'll talk about basic classes of medications and how to combine them and what different types of medications are useful for. So first and foremost, we've seen how adrenaline surges, adrenaline spikes, just this idea of hyperarousal of making too much adrenaline overnight when you're trying to be asleep. Blocking that adrenaline or trying to suppress it is one of the first approaches to improving sleep quality. And there we'll use beta blockers, which block most adrenaline effects. Alpha blockers block some. And then clonidine and guanfacine are medications that actually suppress adrenaline production rather than blocking adrenaline that you've already made. Histamine is becoming a much more widely recognized player in Ehlers-Danlos syndrome as we have come to recognize the prevalence of mast cell activation disorder and mast cell overactivity, somewhat analogous to the idea of the autonomic nervous system overreacting to minor stresses. We find that in many patients, mast cells overreact to minor stimulants. What a lot of people don't realize is that the same histamine that causes wheezing, runny nose, sneezing, itching, flushing, some cause stomach upset, that same histamine is a very stimulating neurotransmitter in your brain. It's essentially almost as stimulating as adrenaline in your brain. So I'll see patients with mast cell disorders who are taking medications to block mast cells in their skin and in their respiratory tract, and other medications to block histamine in their digestive tract, but are leaving extra histamine running around unchecked in their brain. So this is, in a sense, this is the reason why diphenhydramine or Benadryl tends to make people sleepy. Unfortunately, a lot of people have next day hangover from Benadryl. Some people have a paradoxical effect where Benadryl makes them hyper and makes their sleep worse. So I prefer to use something called hydroxyzine, which has the same sedating effects, but also has some pain effects, some anxiety effects. That also relieves itching, does what other antihistamines do. And a lot of my patients find that that's helpful to improve the quality of their sleep. Medications just to reduce this general hyperarousal, being too alert, being too awake, include the benzodiazepines, which are Valium and Ativan and Xanax and Klonopin and that family of drugs. And then a unique medication called Belsomra, which rather than the benzodiazepines work by increasing the levels of calming chemicals in your brain to offset the extra stimulating stuff that's running around. Belsomra actually reduces the activity of one of the wakefulness alertness centers of your brain. So it's occasionally useful, though. If overactivity in that particular area of your brain is not the culprit, then that medication will not help you. And then again, I really can't stress enough how important adequate pain control is to getting a restful night's sleep. So not only are straight painkillers helpful, but muscle relaxants are often helpful. The basic rationale there is that muscles that have been strained all day trying to hold loose joints together often tend to tighten up overnight. So if you're somebody who wakes up stiff and achy every morning, often taking a muscle relaxant overnight will help improve the quality of your sleep. Medications like gabapentin or Neurontin and Lyrica or pregabalin are medications that improve deep sleep, reduce pain, improve sleep quality overall, and tend to be hit or miss. A lot of people do very well with them. For some people, they don't help at all, but they're nice in that they affect both pain and sleep, and don't have any issues with being habit forming or inducing dependence or withdrawal. Other medications, and we could use more of these, we use to increase deep sleep. Trazodone is the best thing we have for increasing deep sleep. Amitriptyline and doxepin are other drugs that can increase deep sleep. As I mentioned, Lyrica and gabapentin also can increase deep sleep. But we really could use some new medications to improve deep sleep. And then lastly, I want to make the point of that sleeping pills, and by that I mean sort of the big three, Ambien, Lunesta, and Sonata, should be used sparingly because they don't reduce arousals, they don't increase deep sleep, they really don't address the underlying problems. Some people do need them to actually get to sleep, but they need to be taken with other things, because that's all you're taking. You're kind of fooling yourself into sleeping, thinking you're sleeping better when you're really not. So as I said, I'm not going to take the time to go through each medication. I've included slides with details in them that for future reference you can go back. I'll mention a couple of these. So propranolol is kind of the original beta blocker, and it is the first beta blocker, and it gets into the brain, so it blocks adrenaline in the brain. So it often helps with racing thoughts, but by the same token, it can occasionally cause nightmares and cause depression. So after propranolol was introduced many decades ago, future beta blockers were developed specifically not to get into the brain. Using propranolol, I start with the smallest dose, which is 10 milligrams. For frame of reference, the maximum daily dose is 240 milligrams. And increase that gradually. It usually lasts 6 hours. Some people need to switch to a long-acting propranolol if they're waking up too soon and it's wearing off. Some people also would take some early in the evening. Very commonly, people find that they have an energy crash in the late afternoon or early evening, but then they get a second wind around 9 or 10 o'clock. If you're getting a second wind at 9:30 or 10 o'clock at night, there's no point in letting yourself get totally wound up by 11 or 12 and then trying to fall asleep. Instead, you need to sort of get ahead of that and take some calming or adrenaline blocking medication at 8 or 9 o'clock to sort of suppress that second wind or block that. And again, the idea that different medications work for different people. If this doesn't work for you, there are others to try. Often, particularly if beta blockers are helpful at night, a smaller dose during the day will be helpful. And if you think back to the roller coaster and the idea that your body is also overreacting to minor stresses during the day, suppressing that tendency to overreact will reduce some symptoms, but also help to conserve energy. So the goal of taking beta blocker during the day is to blunt those adrenaline spikes, those adrenaline surges, that over response to minor stress, without blocking so much adrenaline that it makes your fatigue worse. Whereas at bedtime, the goal is to take enough that you really shut off sympathetic activity as completely as possible. So these are other beta blockers. Each one has a slight wrinkle. I'm not going to bother. You can read through this at your leisure. Clonidine and guanfacine, as I mentioned, these are drugs that suppress adrenaline production rather than blocking it. We'll use these particularly in people with asthma or who have bad allergies, and their allergists have told them not to take a beta blocker. Alpha blockers are an interesting class of drugs, and in particular prazosin. Prazosin has been shown to reduce nightmares in PTSD, where one study showed, quote, a hypersensitivity to adrenaline triggered many of the nightmares. And in a study done by the VA, 75 to 80% of patients, these are troops coming back from the war with flashbacks and nightmares, 75 or 80% of them stopped having nightmares completely with this one inexpensive, many decades old medication. So there are additional studies going on now. But when I first saw the abstract of that study, I was elated because I finally realized that there was at least one other person out there who thought that the autonomic nervous system was important for the regulation of sleep. Benzodiazepines, as I mentioned, as a class, have useful properties. These are your Valium, Xanax, Ativan, Klonopin. They have many helpful properties for sleep. They're sedating, they relieve anxiety, they have some muscle relaxant properties, they reduce movement, and they block adrenaline because essentially they work by raising the levels of calming chemicals in your brain to offset the extra stimulating stuff that's running around. But they have major downsides, which is that they impair cognition, they impair motor performance, they're downers mood-wise, they can suppress respiration, they can make fatigue worse, and if you use them too long, you can get into problems with tolerance, dependence, and withdrawal. In particular, I would highlight clonazepam, which is a drug that sleep doctors like to prescribe because it reduces activity, reduces movement and anxiety, and all kinds of different sleep problems. A good sort of one-size-fits-all drug. Unfortunately, clonazepam often lasts 12 hours and can aggravate morning fatigue. And very often I see people taking clonazepam and I say, gee, you're having problems with fatigue and depression and cognitive function, and you're taking a drug that makes all three of those things worse. So here are some common benzodiazepines. Pain medications, the main reason I put this slide in is just to make the point of how short the list is. Pain medicines, you have Tylenol, you have anti-inflammatories, you have medications like Cymbalta and Savella, which have both mood and pain effects. You have medications like Neurontin and Lyrica, which have both sleep and pain effects. You have some topical or local patches and gels. And then you have your opioids. It's a fairly short list. So if you run through the first half dozen things, or half of those haven't worked, and you're already taking the other ones, and you're still in so much pain you can't sleep, then you might need to consider taking opioids, even just a short-acting opioid at bedtime, to see if that helps improve the quality of your sleep. And then, of course, in some states now, cannabinoids are legal, and some people find them helpful for sleep. Muscle relaxants, very much a different strokes for different folks group of medications. Some people find one works great, another one doesn't work at all. One's too sedating, one's not sedating enough. And often this is a question of just trying different things until you find one that works. Other agents, as I mentioned, these are the drugs that we typically use to try to increase deep sleep, trazodone being the most common. The point there is that this is not a more works better kind of thing. Most people take 50 milligrams and that does what it's going to do for their sleep. Occasionally people take 75 or 100 milligrams, but the antidepressant dose is 300 to 450. So you're not getting much antidepressant effect when you take a small dose to help with sleep. Similarly, amitriptyline, it's a very old antidepressant that's been found to increase in deep sleep, especially in people with pain. And similarly, the antidepressant dose is 200 to 250 milligrams. So if you're taking 10 or 20 or even 50 milligrams at bedtime, you're not likely to get a lot of antidepressant effect from that. And you'll also get, a lot fewer side effects than people used to get on the full antidepressant doses. Doxepin is an interesting medication because it increases deep sleep and it also has some antihistamine properties. The sleeping pills I mentioned, and these are generally things that you should stay away from. Very infrequently, I see people who find melatonin or prescription melatonin analog Rosarum helpful for their sleep. Antidepressants, I mentioned antidepressants because depression tends to make your sleep worse. So like pain, if you're not adequately addressing depression, then you're going to have trouble getting a restful night's sleep. Unfortunately, most of the commonly prescribed antidepressants, including the serotonin reuptake inhibitors, tend to give you a shallower, dreamier sleep, which is why we use the smallest dose that works. And I see many patients who find that doses smaller than the typical antidepressant doses will help them either with anxiety or to reduce that sense of jitteriness that they get from too much adrenaline. The liquid formulations are nice because you don't have to break tablets up into little pieces. You can start with like 1/10 of the standard dose and very slowly increase your dose. Duloxetine or Cymbalta is a medication that has FDA indications both for depression and for pain. As long as you take it in the morning, it does not seem to have any negative effects on sleep. Savella, which was introduced as a fibromyalgia drug, and its cousin Fetsimo, which is marketed as a antidepressant, are essentially the same compound. They have effects both on pain and mood. Sometimes not both. I've had patients who find that these are very helpful for pain, but don't seem to have an effect on their mood, or vice versa. The tricyclics, the older antidepressants, as I mentioned, particularly amitriptyline, generally improve sleep. but typically cause daytime sedation, dry mouth, constipation, all kinds of other things at full antidepressant doses. Bupropion or Wellbutrin impair sleep if taken late in the day. So I generally discourage people from taking the once daily extended release form because it's the most stimulating and energizing of the antidepressants. And you really don't need that extra stimulation and energy overnight. In fact, it's the last thing you need overnight. So I have a lot of patients who take the older sustained release twice a day version of Wellbutrin just once a day in the morning. If you find that you take that in the morning and it's not getting you through that late afternoon crash, then you can take a second dose in the early afternoon, and that will usually wear off before bedtime. Remeron is an unusual antidepressant that has some antihistamine effects, so can improve sleep, but also tends to cause weight gain. So generally we stay away from it, except in people who are trying to gain weight. So in past years, when I've presented these data based on experience in my own practice, my skeptical colleagues would say, well, gee, this is great. You've done this on a few patients in your practice, but, do you have any real data? And I would have to say, well, I only have the two-legged kind, meaning that my patients would tell me things like, I'm stunned, amazed, and grateful at the benefits of taking propranolol. Improvement on sleep quality alone is fantastic. And you can read some of the others, but I know this works because I've been doing this for more than 15 years now, and my patients tell me that this works, and I see people who've been struggling to get better start to get better. Now, thanks to John and the folks at EDS Awareness, I have some real data. I have all this data from the survey that I've shown you. So, in summary, I hope I've convinced you that the most common type of sleep disorder we see in the hypermobility syndromes appears to be characterized by excessive sympathetic activity at night. This is what I call hyperarousal, and that medications that suppress this arousal, offset it, or block it are effective in improving sleep quality, as measured both by sleep study data and by patient reports of symptoms relief. So, and then this is what I often leave people with, especially at the end of a initial visit, or if patients say, okay, well, tell me in the old parable, standing on one leg, tell me what I have to do to get better. And I say, okay, look at this lot. This is what you have to do to get better. You have to work on getting a better night's sleep. You have to work on adequate pain control. You have to work within the bounds of your energy limits. Don't push through fatigue. Do something, rest, do something, rest. You need to be sure you're getting adequate salt and fluid. Most of my patients, I just got some data back yesterday from somebody who's drinking electrolytes and eating salt all the time, and her salt levels came back right at the low end of the normal range. People who think they're doing this usually are still getting too much water and not enough salt. And then limit other stresses where you can. So if we can improve sleep and minimize daytime stresses and improve pain control and gradually replenish autonomic reserves, put more gas in the tank, that will also improve autonomic function, so you won't be wasting so much energy on this crazy overrespond, overcorrect, overreact, roller coaster. Your autonomic nervous system will behave better, your sleep quality will improve. If your sleep quality improves, you'll have more energy, you'll be more active during the day. The more active you are during the day, the better you're going to sleep at night, because your circadian rhythms will be better. And overall, that is how sick people get better. So I want to acknowledge John Furman and EDS Awareness, thank them for inviting me and for all the hard work they do on behalf of the Ehlers-Danlos community. I thank my friends and colleagues, especially Dr. Peter Rowe and David Goldstein, for encouraging me about 15 years ago when I first floated some of these ideas, and everybody but the two of them thought I was nuts. I thank other colleagues, particularly Claire Francomano and Fraser Henderson, for teaching me about Ehlers-Danlos syndrome and stimulating my interest in it, as they asked me to teach them about sleep problems and autonomic dysfunction. And lastly, I always thank my patients for having the confidence in me to let me experiment on them and learn from them, because there is still no published literature to support most of what I have told you tonight. And I leave you with a plug for Claire Smith's fabulously encyclopedic book on understanding hypermobile Ehlers-Danlos and hypermobility spectrum disorder. It's just a fabulous resource. It's a wealth of practical data, summary of research conclusions. You can use it as a reference book. You can read it section by section, page by page. This is available by single copy through the Ehlers-Danlos Society website, or typically what I do is Google Claire Smith hypermobility, and you'll find the link to the page at the Ehlers-Danlos Society site. So I guess I've left plenty of time for questions tonight. I think John may have mentioned earlier, but we'll ask people to sort of try to keep their questions general and not ask for specific medical advice for their own particular medical problems.
Okay, great. Thank you, Dr. Pocinki. It sounds like you've come up with some very interesting information I think all of us can have some use for. So, yes, we do have some questions if you'd like to go to the questions page. And then also anyone who has additional questions, we do have some extra time. So please add your questions by clicking on the question mark at the top of your screen. And I'll turn it back to you, Dr. Pocinki.
Okay. I'm having a little trouble reading these questions. If I can. There we go. Okay. Okay. There's a question about the 2017 articles. In 2017, there was a whole issue of American Journal of Medical Genetics on Ehlers-Danlos syndrome. I think those articles are still available through the Ehlers-Danlos Society website, which is ehlersdanlos.com. Okay, there's a question about upper airway resistance syndrome. So upper airway resistance syndrome is something that I think is being recognized a little bit more commonly. This is not sleep apnea, because sleep apnea usually is a problem with the airway closing off in the throat, but upper airway resistance refers to difficulty getting air through the nose and down into the airway from there. And that can be as disruptive to your sleep as sleep apnea, but can be missed certainly on home apnea testing. Sometimes in the sleep labs, a good technician will be able to spot that and will recognize these as what are called respiratory arousals. Yeah, so those are yeah, so the question is about, why would the sleep study have been read as normal if the person did have significant upper airway resistance syndrome? And that's because it can be missed. It's not an apnea. Apneas and even hypopneas, which are defined as not only disruptions to the continuity of breathing, but they have to be associated with significant drops in oxygen levels. And a lot of people with upper airway resistance syndrome, these respiratory disturbances will be missed on a standard sleep study. My experience has been that the otolaryngologists, the ear, nose, and throat specialists, are more tuned into looking for upper airway resistance syndrome and managing it. This person had asked about the dentist making an appliance to treat upper airway resistance syndrome. I would think that dentists probably are not very familiar with upper airway resistance syndrome, and that would make more sense to consult an ear, nose, and throat person about that. Okay, here's a question about so this is a question from somebody who's taking some medication, Florinef for orthostatic intolerance, Celebrex and Tylenol for pain, but still exhausted and not sleeping well. And unfortunately, as is often the condition, finding a physician who doesn't seem to be able to offer any additional help. It's a it's a struggle. My first guess would be that the Celebrex and Tylenol aren't adequate, and this person may be it may really be pain that's disrupting their sleep, and they might need to go to see a pain specialist or perhaps a rheumatologist or somebody who might be more sympathetic or more comfortable prescribing pain medications than the primary care person or whoever they're working with right now. Okay, there's a question. Are there specific things we should ask sleep doctors to measure monitoring during sleep studies? So that's a very good question. And I think the most important thing that I usually advise people is that, and you may recall the one picture I showed you, that you really want that one page that's called a hypnogram. You want to be able to see all on one page the sleep cycles, the sleep architecture, the heart rate, the breathing patterns, the movement patterns. For example, if you see that every time you rolled over from your side onto your back or your back onto your side, that was associated with a sleep disruption, then that strongly suggests that pain was the problem. And then you can look and see, well, gee, there were a few breathing problems, but if I look at the sleep cycles, I see that those breathing problems didn't disrupt the sleep at all. But if I look over here at the heart rate line, then I'll see it's really the heart rate spikes that disrupted the sleep and not these other breathing problems. So that hypnogram is really the most helpful thing to get from your sleep study. Unfortunately, not all sleep lab software programs will do that, but that's because then you can see that, and then you might be able to help your doctor interpret your sleep study yourself. Okay. There's a question about adrenaline binding to alpha receptors as a cause of a particular type of sleep disturbance in allergic analysis. Yes. So it turns out that I mentioned using the drug prazosin. It turns out that while generally most adrenaline binds to beta sites, and that's associated with both mental alertness and heart racing and increase in blood pressures and the sort of fight or flight physical response, that adrenaline binding to alpha receptors in the brain is particularly associated with vivid dreams and nightmares. And it's one of those things where a lot of people who have lots of dreams and nightmares think that having 3 or 4 dreams is normal, and waking up in the morning and being able to recall every detail of 3 or 4 different dreams is not unusual, because that's what they've always experienced. Some people also believe that they'll say, "Oh, I'm sleeping so much deeper. I'm having all these really vivid dreams," with the misconception that you dream in deep sleep, whereas most people dream in REM. You dream in shallow sleep. And occasionally people will say, "Well, gee, I'm sleeping better. I'm not waking up as much, but I'm still having lots of dreams, and I can remember all the details of my dreams." And then you know that you need to add an alpha blocker as well to whatever else they've been taking. Okay. Yeah, unfortunately, yeah, there was a follow-up question to that, or other medications. Unfortunately, prednisone really seems to be unique in that feature. Other medications that have alpha blocking properties don't seem to have that same ability to reduce dreams and nightmares. The only other thing I mentioned earlier is that that the serotonin type antidepressants can increase shallow sleep, cause more frequent dreams, more vivid dreams. So if you're able to reduce the dose of a serotonin type antidepressant, or take one that you've been taking in the evening and the morning instead, sometimes that can help. Sorry, I'm just reading through questions here. There's some. There's some questions about other approaches to regulating autonomic function, non-pharmacologic approaches. Yeah, we tried. I mean, years ago, we were about to start a study just on biofeedback. I've always wondered about self-hypnosis as an approach to calming down. Certainly, a lot of people find meditation helps. So there are certainly, generally, I have to say that the conventional wisdom that, the first line treatment for having trouble sleeping is cognitive behavioral therapy tends to not be helpful in these syndromes. Hopefully, as I've shown you tonight, this is really more physical than psychophysiologic, and trying to teach yourself to sleep better is not going to be effective if you're in pain or if your body is cranking out adrenaline. Somebody else asked about timing of taking medications. Then I just mentioned the primary culprits there are the antidepressants, and trying to take them in the morning rather than too close to bedtime. Right. So there's a question about home sleep monitors, and I think the latest, I found the latest iterations of things like the Fitbits actually have been pretty helpful. Just the latest, probably since the first of last year, the latest sleep algorithms. Most people who show me their Fitbit data, it looks surprisingly accurate. I'm sure it's not as accurate as spending the night in the sleep lab, because it's not really monitoring things continuously, but rather sort of sampling every so often. But still, they're useful because they can detect the brief arousals that you're not going to be consciously aware of, and avoid the problems of sticking adhesive leads to your scalp to monitor brain waves and so on. Frankly, I'm not sure how wearing a Fitbit on your wrist can tell whether you're in shallow sleep or deep sleep. They can certainly tell whether you're awake, asleep, or whether you're in REM or non-REM. But as I said, recently, the data people have shown me from their Fitbits do seem to be showing that reasonably accurately. Okay. Sorry, somebody asked a question about how to get their GP or their cardiologist to address their autonomic issues. I wish I had an answer for that one. You know, the good thing about the internet is I can do this and send some ideas directly to patients, because I sure have not had much luck getting my physician colleagues interested in learning about these syndromes. Even when I describe this type of sleep disorder to sleep specialists, they're either not interested, or they think it's not as common as it really is, or they'll say things like, well, gee, we see that pattern in some of our just regular insomnia patients have sleep that looks like this. You know, don't you see that in your regular insomnia patients? And I say, no, the patients I see who have this sleep pattern are all hypermobile, and they have other signs and symptoms of autonomic dysfunction. But one of the problems of autonomic dysfunction, of course, is that it falls between specialties, that the neurologists don't learn much about it, the cardiologists don't learn much about it, certainly sleep doctors don't know much about the autonomic nervous system. Preference of where to start with. Okay, there's a question about have a preference where to start with medications. Beta blockers versus pain control. Generally, as I said, you know, if pain is triggering adrenaline that's disrupting your sleep, then first and foremost you want to address the pain and not just block the adrenaline. And this is a very common, again, very common thing. People are hesitant to take medications. And there are times when I'm not sure whether it's pain or adrenaline that's the main culprit, and I'll write somebody a prescription for 4 or 5 strong painkillers and say, just take one at bedtime for a few nights and see whether you sleep better or not. And often it's immediately obvious that people will say, yeah, they really do sleep better. Somebody asked about how to get a diagnosis of Ehlers-Danlos syndrome. That's where I would refer you back to John and EDS Awareness website, because their homepage lists all the support groups around the country, and getting in touch with your nearest support group. They're the ones who are going to know, you know, the EDS friendly and EDS awareness, EDS aware physicians and other health professionals in your area. Somebody asked whether you can get a CPAP or BiPAP, APAP machine if you don't have sleep apnea. Not in this country. Insurance is not gonna let you do that. The question is chronic fatigue associated with fluctuations and poor sleep. Yeah, that's that's a good segue. That's one of the other webinars on this site that I did was entitled something like Breaking the Cycle of Chronic Pain, Poor Sleep, Fatigue, and Depression. So yes, indeed, fatigue is associated with poor sleep, fatigue is associated with pain. All of these things are associated with autonomic dysfunction. Each one tends to aggravate the others. So that is a webinar that I think John told me recently has been watched about 15,000 times. So people relate to that vicious cycle getting stuck in there, and how difficult it is to get out. But you need to recognize that you need to address all those pieces pretty much simultaneously, rather than expecting that fixing any one is going to solve all your problems. Okay. I think I'm getting through. Okay. There's a question about patients trying Aimovig, which is a new migraine preventing drug. My experience so far has been about 50-50, but my concern with that drug is I've seen a lot of patients prescribed it, and there's a couple other drugs in the same class now that have been approved. I see a lot of people who don't have migraine, and it looks like their neurologists have said, well, I don't know what else to do for your headaches, so why don't you try this new drug? And that gets into a whole other, can of worms of 20 or 25 different types of headaches that Ehlers-Danlos patients are predisposed to. So my concern about suddenly having a lot of new migraine preventing drugs is that a lot of people may be misdiagnosed with migraine. Someone asked, can you take an alpha blocker or the beta blocker? Yes, as I mentioned, a lot of people will start with beta blockers, but if they're still having vivid dreams, we'll need to add an alpha blocker as well. Right. So John mentioned earlier, somebody asked about consultations. Sorry, I'm swamped. I'm not available to see patients or even respond to emails or anything. Okay. Somebody just asked about increasing salt intake. The simplest solution, no pun intended, is to minimize how much plain water you drink, to drink electrolyte solutions instead of plain water. Every time you drink plain water, you're diluting out the salt in your system. And the only way for your body to get your salt levels back up are either to hold on to salt or pee out the water you just drank. So it's a problem because patients' thirst seems to be stimulated and they want to drink water all the time. Again, another paradox that drinking too much water can actually make lightheadedness worse, can make swelling worse. So salting your food, drinking electrolytes, and limiting plain water are the most effective ways. What about alpha and beta blockers cause an EpiPen to become ineffective? Well, this is a theoretical concern that EpiPens inject adrenaline into your system. If you're taking adrenaline blocking medications, then the EpiPen might not work. I don't share that concern because my understanding of the autonomic dysfunction is that your body, if you had to use an EpiPen, your body might overreact to it, and it might be a good thing for you to have some beta blocker in your system. But that goes against conventional wisdom. And my friends in the allergy business tell me that I need to be careful to not do that. But I have lots of patients on beta blockers who still occasionally use EpiPens, and they seem to work. But generally, we try to avoid them. Okay. All right. Well, I think I'm running out of steam there, John, and got through a lot of the questions. If we can call it a night.
I think that sounds like a plan, and really appreciate your going through just about all the questions. So I think, and we had some really good questions there as well. So yes, well, we certainly appreciate you, Dr. Pocinki, giving your third presentation here. We appreciate you incorporating some of our EDS survey data, which substantiates many of the things that you're telling us about. So any final comments before we close for the evening?
No, and thank everybody for their interest, and hopefully they can take some of the ideas back to their own physicians and get some new ideas and find some things that are helpful to get them to feel better.
Okay, fantastic. Well, we will be we have recorded this, or will be posted on our site. I think we'll post a link also to the book that you referred to, so that people can easily find that as well.
Great.
And if you have other articles, I know somebody said, oh, how do I get to a couple of the articles? If you have links to a couple of articles that we put on the site that they could easily link to, that'd be fantastic as well.
Okay, I can send you those links.
Okay, super. All right, well, thank you for your presentation this evening, all those that attended. And I think we've learned a lot about sleep disorders and how to deal with it. So okay. We're going to call it a night.
Okay,
so,
thank you, John.
Thank you. Have a good evening. Good night.
Good night, everyone.